And we've got Alistair next, who is a consultant in emergency medicine. And again, extraordinary CVs, but from what I can see, Alistair, you have done that organisational piece, as well as being in the red suit, doing HEMS type work and bringing blood on board. But so I think, can you give us a taste of trying to create calm out of chaos so that we can actually stream these patients in to the right hospital at the right time so that each of these transfusion teams can do their very, very best? Thank you.
Thanks very much, Heidi, for the introduction. And I think involving my name in calm and considered care, probably not the correct phrase, but we'll go with it and see how it goes. Good morning. I think it's Heidi said, I'm Alistair Rennie, consultant in emergency medicine and major trauma in Salford and Greater Manchester. I'm also co-clinically to the Greater Manchester Major Trauma Network. And I suppose for this portion, I'm Associate Medical Director and Strategic Medical Advisor for the North West Ambulance Service. And for those of you that are relevant, I'm Group O positive blood and platelet donator. Don't know if that's relevant. Apparently, it's some fancy things that blood people need to know about. I've been asked to look at, or basically talk about the pre-hospital aspects of mass casualty scenarios and situations. So we're looking at the pre-hospital aspects of transfusion. So the current state we've got is we've got ambulances that fly in the air and we've got ambulances that go on the road. I'm not going to give you any rocket science here. We've currently got 21 charity air ambulances across the entirety of the United Kingdom and one statutory body, which is the Scottish Air Ambulance. So there's 22 separate air ambulances across the UK with kind of various HEMS teams, doctors, paramedic led. And as I said, the vast majority of them are charity. These 10 ambulance trusts in England, the ones that have the four wheels and the big yellow box on the right hand side of it. These National Ambulance Service in Scotland, a National Ambulance Service for Wales, and a National Ambulance Service for Northern Ireland, basically due to the geography. The Isle of Man, the Channel Islands, and Gibraltar all have separate ambulance services. Approximately, if we just move on, perhaps 3/4 of all air ambulances have some variation of blood and or plasma on board. So the donations that you guys all deal with, or volunteers deal with in the centres, comes into blood, it goes into hospitals, but also the air ambulance products, and have been since 2012, when London Air Ambulance was the first air ambulance to actually take blood to the patient at the point of injury, whether that be the roadside, in their house, etc. I had the pleasure of flying with the Kent Surrey Sussex Air Ambulance when they instituted blood on board in 2013, when we actually took blood, and I've actually given roadside blood donations. It's not as easy as straightforward as it is in a hospital, but you still have, I think as Kate said, you've still got the rigorous checks and traceability to make sure that any blood sample given, you know exactly where it's going through and where it ends up. So that's the air ambulance. Some local basic schemes, which are pre-hospital care provider schemes, usually car-based volunteers, GPs, A&E, that kind of idea, do have local arrangements with local hospitals that they can request and take blood to the scene of an incident, a car crash, etc., that's been happened. But again, that's a very, very local ad hoc arrangement. There is no land ambulance in the UK, so no national ambulance service that has blood on board, although there are trials with freeze-dried plasma, etc., going on, but none of them have blood on board. Each air ambulance usually carries between 4 and 8 units of packed red cells, plasma, etc., in various storage compartments, and it costs approximately about £2,000 per transfusion to a patient, and that's a global cost of the blood, the kit, the equipment, the consumables, the training, and the ongoing governance around individual blood transfusions. So as you can understand, it's a heck of a lot more expensive than it is doing it in a big, nice, clean, shiny, well-lit hospital environment. If we just move on, perhaps, please. So where are we in research? What is research? What evidence have we got that we actually take blood out of hospitals? If we look at the PAMPER study, I would like to point out that other generic nappies are available, but that's just a random picture of Pampers I thought, because I just couldn't avoid it. PAMPER study was published in New England Journal of Medicine 2018, which was looking at American stateside pre-hospital plasma from air transport. So it was medical plasma, air transport with people given medical plasma at the sign of injuries, and they found a decrease in 30-day mortality, so that indicating pre-hospital plasma transfusions at the point of injury may well have an increased survivability. Excuse me. It was slightly counteracted by further studies, so it was a little bit nebulous, but they were doing that. In the UK, we published or started the refill trial, which effectively was the resuscitation with pre-hospital blood products, and it was comparing packed red cells blood versus standard practice, which was saline, 0.9% saline. It published in 2022, and it was actually stopped early due to COVID, and there actually wasn't any demonstrated benefit of giving people at point of injury packed red cells versus standard treatment we have, which led us on to the SWIFT trial. So it's the study of whole blood in frontline trauma, which is actively ongoing just now, started in 2022, and it's going through to 2025, which is involving 10 of our air ambulance charities, including London, including the Northwest where I am, including Kent, Sussex, etc. Looking at whole blood versus packed red cells and plasma, rather than individual components. And they've got 472 patients recruited to that out of an estimated number of 848, which is what they require. So the research was initially promising, but still a little bit nebulous as to whether we actually should be giving blood to people with injury very much earlier in their journey. If you can go on, please. It's fine, it's blank slide. And then this happened. If you go on. This Manchester Arena. So it was 2017. I had the horror, pleasure, joy, honour, whatever you want to say, of actually responding to the Manchester Arena inquiry. I was working clinically in the emergency department and received the largest number of casualties. So I coordinated both the adult and the paediatric side, and I have a very personal interaction because 3 of the people that died in my hospital. Georgina, John and Safi were very, very close to my heart, and specifically, if we move on one more, they were very specific in my heart, because on the right hand side it was the Manchester Arena inquiry volume 2 response, which is Sir John Saunders for the public inquiry, who actually responded that John Atchison could and probably should have survived the attack on the arena because he had compressible hemorrhage and effectively bled to death. The issues around Safi, the youngest Safi Rose Roussos, were debatable as to whether she could have survived longer to hospital or whether she actually had an injury volume that was overwhelming her system and she would have died. Of the 180 odd recommendations from Sir John Saunders, I've picked out a couple of them and I have paraphrased them slightly, that he effectively said, having gone very, very forensic detail, that air ambulances across the United Kingdom should be integrated into the emergency response to major incidents. So local emergency plans with the ambulance service, local government, etc., they should be included, which is a finding from the July 7th bombings as well. And he also did recommendation 120, 121, which is HEART, which is specialist trained paramedics, should be trained to administer freeze-dried plasma and or intramuscular TXA. We all give TXA intravenously, but it should be intramuscular at the scene of injury to increase and speed up that treatment course. If we move on, so that brought to the issue of what about blood to scene? And Kate's already summarised that we don't do blood to scene. We don't. Simple as that, because there's lots and lots of problems with it. So John Saunders came up and said, well, what is the problem? And there was lots and lots of detailed evidence as to why it wasn't an easy option to do, but the challenge back to the health community was, well, why not? Crack on with it. What are the problems? So I'm going to go slightly left field here, and this isn't a VVox, but this is where we're going to open your imagination. So we move on. Yep. So there you go. Sea France, it's a ferry. It's over the White Cliffs of Dover. I did say to Fats and Heidi when they were chairing that I wasn't going to make this London-based. So I've specifically not made this London-based, but there is a cross-channel ferry. Go with it. Okay, it's coming into Dover. There we go. Nothing really much happening. If we just move on one. So it's Dover, or actually anywhere more local to you, because I know we did the word cloud earlier. So we've got people from all over the United Kingdom, all over England, and hello to Tameside because you're very, very close to me. So choose anywhere that might be remote, and specifically remote that's not near a population centre. It's not near a major trauma centre. Reports are coming through on Twitter. I should have updated that to be X, but unfortunately I'm very old-fashioned. It will stay as Twitter. There's been reports come through of stabbing on a ferry and several are injured. There you go. That's all you got. Haven't got anything else. But then you get some images coming through, and these images of query multiple attackers have been seen. You go, Right, okay, might be more interesting. The scenario I'm going to give you is I'm going to give you a methane, which is standard communication for major incidents. We've not declared a major incident because individually in your individual roles, wherever you are across the United Kingdom, this may or may not affect you. If you happen to be up in Glasgow, it's not going to affect you at all. But major incident declared or standby, we haven't decided yet. The exact location is the English Channel, which is quite big. The type of incident, which is a knife attack on a ferry. And the hazards that we've got are multiple assailants, is at least 3+. I'm going to ignore the entire hazards of being a ferry. Access is only via air, which effectively is the Coast Guard with winch capability, because you can't land a helicopter on a cross-channel ferry. The numbers we've got are 40+ injured, including children. These unknown any fatalities. There are no emergency services present at the scene because it's a ferry. But en route, you've got the police, which will be the armed police as well for Kent. You've got Kent Fire and Rescue. You've got CCAM, the South East Coast Ambulance Service. You've got KSS, not at all biased in choosing Kent South Sussex Air Ambulance just because I flew with them. You've got the Coast Guard and RNLI have launched boats as well because it's a ferry in the channel. The ferry is due to arrive in Dover in the next 25 minutes. And the reason I've chosen this, because it's a possibility when I was down in Kent, this was a worry for me, is your nearest major trauma centre is King's in London. It's an approximately 1 hour 15-minute blue light journey via ambulance. And I choose this because I have transported a major trauma patient from Dover to King's by road, by ambulance, and it took quite a long time. So, but this is also taking it away from the London, Westminster, London Bridge, the Manchester Arena, and things. It's taking it out into the community, so it could actually happen anywhere. It could be in your local environment. So we move on. So what are your thoughts? What are your plans? Any concerns? Any concerns for you in your role? What are you going to be doing about it? Kate's summarised for us in the first presentation about the NSBTS. What do we do? But what do you do in your individual role that you've got, your individual hospital, your individual department? Does it affect your day job? Will this affect you? What you're planning to do today, Wednesday? Will it plan Thursday? Will it affect Friday, Saturday, or Sunday? Sure, thank you. So if we get an update from the scene, and this is post-initial triage, so a new outcome from Manchester was an updated triage screen, which was the 10-second triage, which is all emergency services, not just healthcare, but police, fire, Coast Guard, mountain rescue. We've all got 10-second triage, which is a new process away from 7-sort. So we don't declare anyone dead. It's very, very rapid, and it means anyone can do it. So it's one of the inquiries that started, went live UK-wide on the 1st of April of this year. So the update we have is that these 10 not breathing, they'll be labelled with a grey slap wristband, which says not breathing. So they're not dead, they're just not breathing, they're placed into the recovery position. We've got 54 injured, of which 34 have torso penetrating injuries. These multiple major hemorrhages, and the assailants are still barricaded in with Query hostages. The HEMS team have arrived and they've requested additional blood. And to update you for TST, it very much focuses more casualties into the P1 critically injured scenario who require urgent treatment, looking at if you've got major hemorrhage or penetrating trauma, your class is a P1 priority because that is potentially reversible, taking on the findings from John at the Manchester Arena inquiry, who potentially had compressible life-saving hemorrhage that could have been stopped and could have been resuscitated. So we'll move on. So that's your issue, that's your problem, but that's your scenario. What problems, what issues, and what solutions do we have? Kate's already said we don't take blood to scene. We've been challenged through public inquiry. Do we have to reconsider that as a healthcare system and as a society system? So problems, issues, and solutions. There's lots of problems, there's lots of issues, not that many solutions right now. And I'm not going to give you solutions. I'm going to open your mind to a bit of thought process as to what you think. So move on. First problem I always have is communication. Kate's summarised it earlier. Communication, #1 failing in all UK, but certainly worldwide, all major incidents is communication. Simple talking to people. But the communication we've got is who tells you in your role about what's happened. If you happen to be working in the blood transfusion lab or hematology or A&E at Ashford in Kent, which is the nearest hospital, because Dover's got a community cottage hospital with about 6 beds for care of the elderly, frailty patients. So the nearest hospital is Ashford, 40 minutes, 25 minutes further up the road. So who tells you of what's happened? Who tells the blood transfusion service? In the northwest where I'm based, the ambulance service is part of the call-in list for major incident have now included the National Blood Transfusion Service. So that goes to the regional office. How does it disseminate down to each individual lab or each individual centre? Are you reliant on your coexisting hospital to tell you, in which case you as a central lab might be supplying 5 hospitals? Are all 5 hospitals going to tell you, or do you tell each hospital? How do you tell your individual staff? And then we've got the HEMS team that have gone to scene. We've got the scene communications. They're requesting more kit and blood and resource. Pre-hospital care air ambulance teams come under the umbrella of an ambulance service. The ambulance service reports centrally. We saw the diagram from Kate all the way, but how do you get an ambulance service speaking to a blood transfusion service or a hospital? And then we've got the issues of how do we get information into the hospital? How does it work? So you can tell straight away communication is going to fall down, and we're remote. That's why we so much now rely on social media. If we move on, the next problem we've got is location. There's a big red arrow somewhere right in the middle, which is centred roughly on Stockport, which is where I'm speaking to you from right now. So if I tell you, right, there you go, there's the UK. So location's an issue as well. I've already given you a scenario that's based in Dover, an hour and 15 minutes away from the nearest major trauma centre. One of the benefits, very bizarre way to say it, one of the benefits of Manchester was that we had 3 major trauma centres within a 5-mile radius of the incident. The London attacks happened where you had multiple major trauma centres. If you go and look at the stabbing at the school in Wales, was it a couple of weeks ago? They were a fair wee distance away, but it was towards Cardiff end. If something happens up in Bangor in the northwest of Wales, you've got a significant journey to go. You've got a significant journey to transport patients that are potentially bleeding to death. But also, where's your nearest major trauma centres? Where are you sending those patients to? Where are the regional blood transfusion centres? Where are your donor sites? We've already alluded to, but your regional centres may well be sending a lot of blood to an individual or neighbouring major trauma sites with mutual aid. They may well have to send it quite a significant distance to get to that initial first strike hospital. So location is important for, number one, if we are going to consider sending more products to the scene or supporting the scene closer, where have we got storage from it? And then if we move on to the next 2 sort of big issues, so logistics, the bane of the ambulance service. I've got one of my colleagues who describes the ambulance service as a logistics service. It's Amazon. We take people that are injured and we patch them up in little boxes and we transport them to hospital. That's what we are. But we've got issues with logistics. So top left is just a standard blood giving kit. So if we want to give blood, the air ambulance carry several kits of this. But if you want to provide additional products, you need additional kit. We've got a weight limit in air ambulances. We've got a space limit in ambulances. So where do we get kit? If we've got 30 or 40 people that are going to require all of them a 1-hour journey by road, you can put them in the back of an ambulance, leave them bleeding for an hour, and at the other end, you're not going to have 40 people by simple physics. So, but where do we get the kit to suddenly have lots of it to go down? The other logistics are actually moving the blood product itself. The images, the 3 images on the right are from Great North Air Ambulance. So the top right is a specialist, the Credo box, a specialist blood storage box. It's kind of generic to air ambulances currently. It's insulated, data controlled. It can take between 4 and 8 units. They last for between either 12 or 24 hours, and they're data sensitive. So as soon as you open them, effectively a microchip clicks off that you've increased the temperature, and potentially you've got a set amount of time to use that blood, or else it's wasted. And you can, certain times it goes back to the lab and they analyze it to make sure for the traceability that we've actually used it appropriately. We rely on, the bottom left is the volunteer blood bikers that actually restock and resupply the air ambulance teams currently in the UK. But if we're going to move people to scene, do we have to utilise some blood bikes? Do we utilise the little blood transfusion vans with the blue lights? Where do we have these? And depending on your location, are you moving blood to a neighbouring major trauma centre or to the scene? How do we get it? How do we have these? These guys are all volunteers. And then the right hand side is buddy light warmers, is a blood or fluid warmer, because the worst thing you want to do is get to scene where somebody's been critically injured and then start pumping 4 degrees fluid into them, because that's not going to help. So we need the kit associated with these patients, whether it's at the scene, whether it's a casualty clearing station, or even ongoing in the ambulance whilst being transported to the major trauma centre. As soon as you put it in an ambulance and that ambulance leaves, you've lost that bit of kit for the next patient. So do we have a ready supply of these? No, we don't. We've got very, very few of these. There's only 3 or 4 on each air ambulance because they use them for each individual patient. So The other logistic we've got is enhanced pre-hospital care that currently give blood. It's not 24/7 across the entire UK. So what do we do with it? And any blood that's not used, where does it go? Does it go with the patient? Does it go back to the centre that sent it? Lots and lots of questions we've got to work it out. And we just move on fast. So this comes to the crux of the problem, which is governance. How do we don't do it just now because it's incredibly difficult. These MRHA policies that you've got to have a medical authority, you've got to have somebody prescribing the blood. You need to know who they are. You've got to do all your checks. You've got to do the checks on the blood from donor right the way through to recipient. There's a standard paper trail that we can track that entire unit of blood the entire way in case there's an issue. If you're at the scene, if you're a mass casualty scenario, your casualty clearing station or the ambulance setup or a field hospital effectively, what is the authorization? There's work being looked at to say, can it be remote medical authority? Paramedics, the air ambulance paramedics in the Northwest have all been trained in the governance that they can now give blood transfusions without a doctor present at the patient site, but they still have to phone myself or one of my colleagues who are remote, who give them top cover as medical advisors on call, that we then have to do a clinical discussion with them to make sure that the risks and benefits and actually all the checks and balances have been done. So we might be able to get rid of a prescribing doctor, but then it's the traceability. Oh, sorry, back. Traceability, the ID labels. How do we follow that individual blood and that individual patient through who we may not know a name for, and they may be scattered to 4 or 5 different hospitals? We've also got the issue of pre-transfusion samples. Most air ambulances will try and take a pre-transfusion sample to help the labs with that patient's original blood grouping. We've got issues with kit with different bottle sampling, and where does that sample go to? So do we have? No, we don't. Do we have an activation protocol or policy for blood to scene? We actually don't, but it's something we might need to inquire about, we might need to look into. And then we've got the entire issues of if there is a blood reaction, what's the treatment? Do we have the appropriate treatment at scene? How do we document it and how do we follow it up? So we need this based on clinical decision making, and how do we model how much blood may well be required at scene. Some of the work done by Simon Glasgow is looking at 1 to 2 units per P1 triage category patient can improve mortality, but that's part of his PhD. We haven't modelled it in real life, but it's given an indication as to where we're going to. So if we move on, sorry, thanks. So we've got these patients, we've miraculously got a load of blood. You know, we've gone and bled somebody in Dover, we've given them all blood, and then we have to send these patients off places. So we do dispersal. The ambulance service is responsible for dispersal. I'm showing you a picture of my hometown Glasgow because that's the underground, that's the map of the subway in Glasgow, which is dead simple. It's called the Clockwork Orange because it's a circle. You go in at one place and you get off, you keep going right the way around, you can come back again. Doesn't work so well in the NHS because we've got hospitals dispersed all over the place. But the ambulance services have come together, thank you, and actually come up with dispersal frameworks. If you move on, Fats. So you've got all these patients. This is the Arena Concourse. This is Victoria Station in Manchester. You've got a bunch of patients lying there with lots of people around. Now what do we do with them? We've stabilised them. We could send them all to the nearest hospital, or do we send them to the most appropriate hospital? Bearing in mind the nearest hospital, you might have stripped all of the blood, all of the analgesia, all of the drugs, etc., to support them, to support the scene. Is it appropriate to send them to the nearest hospital, or do you send them to the best hospital that needs their care? So we move on one. The ambulance services have all come up with mass casualty dispersal charts. This is the GM mass casualty dispersal chart. The top box is P1, the most critically injured. So Salford Royal and MRI have both agreed to take 20 P1s in the first 2 hours. So these are 20 of the most critically injured patients in the first 2 hours of a major incident. On the right hand side is children. So Royal Manchester Children's Hospital have said they will take 20 P1s in the first 2 hours as well. The amber box is P2, so that's our trauma units. The green box is P3s or AN other. And the bottom left hand side, sorry, it's a bit blurry, my apologies. We've got also for the business as usual aspects is that PCI, so cardiac, will flip to Wythenshawe, one of our local emergency hospitals. So they'll do a 24-hour PCI hotline so that normal patients are not disadvantaged. The hyperacute stroke unit, which is housed at Salford, will move to Fairfield and Bury so that we're not disadvantaging business as usual patients. And this is just within this is within the GM system. If we've got more than 40 P1 casualties, which this incident may well have created, if we go to the next slide, which is really complex, and I apologise right now, this is a regional. So this is the Northwest Ambulance Service. This is what I get to look at the event of a major incident. So the across left-hand side is all the different hospital specialities of what each hospital site has. Across the top bar and the various different blues and purples and sort of teals, that's the different regions. So you've got from left to right, Cheshire, Mersey, Greater Manchester, Cumbria and Lancs, the Children's, and then the far right hand side is the purple one is the Northern Network based out of Newcastle. Because if you have an incident up in Carlisle, Newcastle is your nearest major trauma centre. And then just below it is P1, P2, what they can take. This for me is an A3 piece of paper. But this tells me where to send the most appropriate patients, so that actually when we've been at scene and we've resuscitated patients and we've got them stabilized as we can, we're sending them to the most appropriate site, not the nearest site. So the most appropriate site to improve their chances of survival, to hopefully stay alive and be discharged, taking on the recommendations from John Saunders. So this is what we've got currently. Part of the findings from John Saunders was that challenge the health service. What do we do? So under the auspices of NHS England, the clinical response to major incidents subgroup under the direction of National Clinical Director and National EPR Director are looking at various different avenues. One of them was triage, to make sure people are triaged appropriately. One of them is the skill set of at scene, looking at the enhanced pre-hospital care service. One of them is looking at analgesia. You'll have seen in the news about fentanyl or opioid lollipops. Again, it has similar issues with blood in terms of it's a controlled drug, the governance, the prescribing, the documentation. How do we recognise that? One of the aspects they were challenged to look at was blood at scene, and work in this aspect has been led by Anne Weaver, who's the National Speciality Advisor for Major Trauma, former clinical director of London Air Ambulance, but also as a person who instituted blood on board on the London Air Ambulance. So she's exploring all of these topics, and we're now at the beginnings of going out into the wider health community to ask advice and help to say, can we make this feasible? Can we go back to Sir John Saunders and the Department of Health and the Department of Justice to say this is something that we can do, that if we've got a major incident in the future, we can optimise patients' chances of survivability by treating them at the scene as quickly as possible. If you just move on to the last slide. Cool. So in summary, a very brief whistle-stop tour of the current state. Some ambulances fly, some drive. The flying ones have got blood, the driving ones don't. The ongoing advancements we're looking at in terms of research is who actually needs blood, and is there a clinical benefit? If there's no clinical benefit, then it's very simple, we don't do it. The future is with the clinical response to major incidents. Can we actually treat these patients quicker at the point of injury to reduce their morbidity and mortality? And then the challenges, which are massive, and we don't have an answer for them, but it is genuinely work in progress, and we will require all the help from all of you lot. And in that aspect, last slide. I'm going to say thank you very much, and thank you for your time.
Thank you so much, Alistair. You've given us so many challenges, but I think you also give us something to look forward to the future. But I'm just going to pick up on a few of the themes you gave us, which was around triage, the whole business of sorting, which although comes out of the clinical arena, I think is a concept that's also been embraced within the laboratory services, that whole business of organising themselves in such a way that the most severely injured are treated. And I think Julie will pick this up in our afternoon, and Rachel has champions the role of our nursing community in this role. So I think that's wonderful. Logistics is almost this audience's bread and butter. They are so successful in terms of their cold chain management, but you now want them to project it far forward. And I think we need to leave Anne and her team. I know FATS is supporting, but so I think it is something to be prepared for. And the SWIFT trial clearly will give us an indication whether simplification through the use of whole blood might speed up and really address the human factors piece. So what I'm going to do now is thank you